we have Dr. Arulmozhi Varman to take on his topic on horizontal chop versus vertical chop, the critical tips. And his duration of talk is 6 minutes. But more importantly, Dr. Arulmozhi Varman is one amazing cataract and refractive surgeon, medical director at the Uma Eye Clinic, and presently is the president of our Tamil Nadu Ophthalmic Society. And let's hear from him about horizontal versus vertical chop.
Thank you, Chitra. It's a pleasure to be here. Thank you for the introduction. So let's say, what is phaco chop? Phaco chop, can you hear me?
Yes, we can hear you.
Phaco chop is where you hold the cataract or at the nucleus with vacuum, hold it with the phaco tip, enter in, lollipop it, then use the chopper to break up the cataract into smaller pieces. That gives you the ability to aspirate out the cataract efficiently with lesser energy. There are two ways that you can do this. You have this so-called horizontal chop and a so-called vertical chop. I rather call it as a central chop, the vertical chop as a central chop, and the horizontal as a peripheral chop. That actually is more descriptive than saying horizontal vertical, but we'll stick with whatever is being used. In the horizontal chop, the nucleus is impaled in the center, held with vacuum. A blunt chopper is taken horizontally under the rexus, and then it's at the point where you think you've reached the equator, you turn the chopper vertically, then you break up the nucleus by drawing the chopper towards the phaco tip and separate. That means you start the chop at the periphery and proceed to the center and take it out, divide it towards that. In vertical chop, the nucleus is impaled the same way in the center, but you use a longer, sharper chopper and you enter vertically into the substance of the nucleus within the rexus margin. You don't go beyond the rexus margin. And then you draw these two instruments together and separate. So you get a central chop where you break up the center perfectly. So this is where the two different chops come in. So what is the advantage and disadvantage? The horizontal chop, the advantage is basically that it is very predictable. It's easy to teach, and every time you do it, you're pretty much sure it will work perfectly. Disadvantage from my point of view, it's partly a blind procedure. When you go under the rexus and you go towards the equator, you're just imagining where the equator is and turning around. That's one. But it becomes far more blind when it's a small pupil. Or you start off with a moderate pupil, done the rexus. As you do the surgery, the pupil comes down. You really can't see the edge of the rexus, and then you'll have to go under it by touch and feel, as I say. And that also makes it a totally blind procedure. Third, it is very difficult to do this where there is no cortex and epinuclear cushion. Absolutely large brown nucleus, trying to get under that every time perfectly is a bit of an issue. So these are the difficulties horizontal chop. In the vertical chop, advantages, it's under perfect visualization. It is safe in small pupils also, and also in cases where the cortex epinucleus is almost absent. So it's everything under vision. Disadvantage is that every time you do the chop, a vertical chop, it can break a little differently. You can't really predict how the nucleus is going to split at that particular time. And it's also a little more difficult to teach and master compared to the horizontal chop. So let's look at the videos. I don't do horizontal chop at all. This I picked up from the net. So this is where you clear up. You get ready there. Take a blunt chopper, which is long. Go under the rexus. You can see that. Hold the nucleus at the very edge. Then you can impale at this point by holding it and then draw the chopper forward. So you find whether it's a hard cataract or soft cataract, it's a predictable chop. You're starting the chop in the periphery and then you're coming to the center. You're very much sure that you will get a perfect chop every time. But is that possible to do this kind of a surgery in every single case? So let's take this kind of an issue where it's a very, very hypermature cataract. I'll just speed it up a bit for time. The lens, the capsule was fibrosed. So we had to use, we couldn't hold it with a microrexus forceps. And we have to do, actually even cut at one point to start with getting the rexus a little better. It keeps coming on. At this point, you'll find there's a fibrosis, and any further pull is going to pull on the whole zonules.
Doctor, time is over.
You said 6 minutes. How's it?
Yes, 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 yes.
Okay, 6 minutes definitely is not over. So we use a scissor to cut. Now we'll speed this up. I'll show you this vertical chop. Now I'm using a sharp chopper, cleaned it up, make a small punch right at the top, hold, enter vertically right there within the rexus, and break. So you're staying absolutely within the center. So you know where you are, what you're doing, and everything is under visualization, the second chop. So you're staying well within the rexus, and you get a very good chop. But the difficulty here is vertically impaling with a sharp chopper and using it to break it up. So let me speed this up also, and then go to one more video, and I'll end my talk. We'll go to the next one. So this is showing how a vertical chop is done. How would you handle this kind of a situation? You have a small pupil, hard cataract. So I do a stretch. Do a rexus. Now, in this kind of a situation, you can't see the edge of the rexus. Trying to go under where you have hardly any nucleus, epinucleus or cortex is very difficult. So you're forced to stay in the center and you do a perfect job. It is not at all difficult provided you follow the lollipopping technique. Lollipop, enter vertically, and then separate. With this, what appears to be a small pupil with all the difficulties, hard cataract, is done quite easily, very efficiently. So coming back to the pros and cons. Horizontal chop is more easy to teach, is more predictable, is something that somebody can easily follow. Difficulties, you'll have to get under the rexus every time. If the rexus is not visible, or you make a mistake, or the pupil is small, you get into trouble. If the epinucleus or cortex is not there, it becomes very difficult. Vis-a-vis, the vertical chop is far more efficient, a little more difficult to master or teach, but once you've got it, it's perfectly easy to do and you'll get excellent results. Thank you.
Thank you very much. That was a lovely presentation, Dr. Arul. Dr. Tithial, I would want to ask you, what would you feel is the best orientation of the bevel of the phaco tip?
I think, it depends which type of tip you're using, angulation, because most of us are using nowadays, Kelvin modified tips. The bevel should be, should be facing towards your side so that you can have a better feel and hold. And the depth is also very important. Whatever bevel you use, the depth is important. That's why a little trench sometimes does help you. Or you have to go very hard onto a central part of the nucleus to hold. What Dr. Arul was talking about is very clear, like, whichever tip you use, it may be a 30 degree, 45 degree, because 30 degree is the one which most people are comfortable with. If you have a good hold, you can do any type of chop. I think the hold is very important. And sometimes you have to have a multi-hold also. You have a primary chop you're doing, it may not be complete, so you can go deeper and deeper, hold it properly. So I think 30 degree is the best one. And if you are using an ozil system, better to have a visible tip so that you can see a proper placement into the depth also.
Tamil, can you ask the second question?
Yeah, Dr. Kiranjit sir, do you change your settings when you're shifting from a 2.2 millimeter incision to 2.8? Sometimes the indigenous eye will requires a 2.8 millimeter incision. Do you shift your phaco parameters, change it?
No, I never go through a 2.2 millimeter NCN. I always go through a 2.8 millimeters NCN. And as far as this chopping is concerned, actually we are trying to teach the young generation. The important thing is we have to keep our endothelium safe because I belong to a old thought school. So what I don't indulge in too much of chopping, whether it's a vertical chop or a horizontal. I do this divide and conquer. By divide and conquer, you actually decrease the size of the segment you are going to pull out through the rexes and less chances of endothelial damage. So I think that divide and conquer is still very good as far as hard cataracts are concerned.
Yes. Since all of you all are there, I thought I'll get Naren also involved. Naren, do you believe that hydrodelineation makes your horizontal chop better? That is, assuming that you do horizontal chop too.
Yeah, thank you, ma'am. So I think it really depends. I mean, I personally do not do hydrodelineation unless it is a posterior polar cataract compromised posterior capsule. Most of my chops are vertical, but personally, I don't have much of experience between in horizontal chops, but I've done in my initial training time. But I would say is if I mean the whole purpose is you need to have a nice clear cut chops with the posterior pole also, I mean posterior plate also being separated. I think most of the surgeons do without hydrodelineation. But what happens in very soft cataracts, some people do use a technique where they hydrodelinate, pop up the central nucleus part and then remove the epinucleus. That's also a wonderful technique. Yes.
No, actually, hydrodelineation does help because in soft cataracts, but the adult soft cataracts, not the very soft cataract, when you hydrodelinate, you are actually making an outline of the endonucleus, and you can very easily chop it into pieces and get it out. Just one simple, easy way to do it. The last question before we go on, Ramurthy, would you have a particular technique of chopping for a particular case, or like majority seem to be all for vertical chop only? Would you change your technique for a particular case?
I use a fairly standardized technique in the sense that, like Dr. Tiklal said, I always make a small subincisional groove from the rexus margin up to almost a little short of the center. Where it's a soft cataract or a hard cataract, I feel that it gives enough purchase onto the meat of the nucleus. Very often, sometimes in a very soft cataracts, it's really not necessary. You can remove it by just carousling. I think most of us don't do the classical vertical or horizontal chop. It's more a combination like vertical chop. The classical method was supposed to be just beyond the phaco tip. You bury the phaco needle and move them in the opposite direction to chop. Well, the other one, you go all the way, the horizontal chop, you go all the way up to the equator. But basically, once I get a purchase onto the nucleus, I just go beyond the rexus margin and then bury the tip of the chopper into the material of the nucleus. The tip may vary depending upon the hardness of the nucleus, then draw them together. So I think it's a combination technique, and I don't know whether others will agree that most of us have gone away from the classical vertical and horizontal chop that was described, and it's more a mix of both that we use, and it seems to work well in most of our hands.
Thank you. Yes, Arjun?
Yeah, so I totally agree what Dr. Ramurthy has said, but one like situation where you have to do horizontal chop, otherwise you're not able to chop is a Morganian cataract, where you don't have any support there. It's a totally mobile nucleus. So in that case, I always bury tip in the center and get your chopper from the equator of the lens to divide it into smaller pieces.
Yes.
Otherwise, I agree that it's a mix of, it's not a classical vertical or horizontal we do. It's a mix of chopping technique which we use.
So
That's
Harshul,
that's a cracking the
Sir.
nucleus, not the chopping. What Harshul is talking about is basically cracking the nucleus from periphery, and it's
Yes.
possible in these type of cases.
Yeah, hypermature cataracts.
Yeah.
In those
So-
cases, the nucleus actually prolapses into the anterior chamber. It's a small hard nut, and you have to cut